Hello everyone, I'm Dr. Yang from Joint Shantou International Eye Center of Shantou University and the Chinese University of Hong Kong. Today's topic is acute angle closure glaucoma. First, let's see a case. A 68-year-old woman presented to the emergency room with a sudden drop in vision and pain in her right eye for 2 days, associated with headache and nausea. Her visual acuity was 0.05 in the right eye and 0.6 in the left. Her intraocular pressure was 54 mm mercury on the right and 40 mm mercury on the left. From the picture, we can see conjunctival hyperemia, corneal edema, and dilate pupil. So, what's the most likely diagnosis? Can you describe the characteristics of this patient that help you make the diagnosis? Hope you can answer these 2 questions after this section. The objective of this section is to describe the clinical features of acute angle closure glaucoma attack. So, what's acute angle closure glaucoma? We know that primary angle closure glaucoma is a major cause of blindness worldwide, characterized by increased intraocular pressure, IOP, and optic nerve damage. Acute angle closure glaucoma attack is a serious condition caused by a rapid or sudden increase in IOP, the pressure within the eye. In order to understand the mechanism of acute angle closure glaucoma attack, we first need to know the normal aqueous humor circulation pathway. In the normal eye, aqueous humor is continuously produced and drained. The picture shows us how aqueous humor normally circulates. From the red arrow in the picture, we can see that aqueous humor is initially produced by the ciliary body and passes through the pupil to the anterior chamber, through the anterior chamber to the trabecular meshwork, then to the sclerovenous sinus, and finally back to the blood circulation. The dynamic balance of aqueous humor production and drainage ensures normal IOP. High IOP is caused by an imbalance in the production and drainage of aqueous humor. This picture shows what exactly happens in the eye during an acute angle closure glaucoma attack. We can see the anterior chamber is shallow, the angle is close and blocked by the pupil, preventing the aqueous humor from draining out by the trabecular meshwork. Aqueous humor has to flow in the opposite direction, gradually accumulates within the eye, and eventually leads to raised intraocular pressure. High IOP can cause optic nerve damage and corneal edema, resulting in decreased vision and pain. Patients with acute angle closure glaucoma attack usually complain of decreased vision, eye pain, headache, red eye, nausea, and even vomiting, and halos. In acute angle closure glaucoma attack, IOP increased dramatically. The scleral and ciliary body are congested and swollen, which presses on the trigeminal nerve terminal. The pain reflects back to the ophthalmic branch and its domitum, causing headache. Due to the nerve connections between the trigeminal nerve, the vagus nerve center, and the medulla oblongata center, when the IOP increases sharply, headache develops, nausea and even vomiting often occur. I would like to thank Dr. Tan in our hospital for providing these pictures. In acute angle closure glaucoma, there are some signs that help us make the diagnosis. The normal IOP is less than 21 mm mercury, while IOP in a patient will be markedly increased, usually more than 50 mm mercury. Slit lamp examination can reveal conjunctival hyperemia, corneal edema, shallow anterior chamber, dilated pupil, and even pigmentation and glaucomatous flecks on the anterior capsule. Investigations mainly focus on 2 aspects: the morphology and function of anterior chamber angle and optic nerve. Gonioscopy allows the structure in the anterior chamber angle to be visualized, so we can assess the degree of angle stenosis. UBM is a contact ultrasound examination, while OCT is a non-contact optical examination. UBM is used for imaging the anterior segment of the eye. It can reveal the anterior chamber angle, ciliary body, and even the lens uniolar. Anterior segment OCT can also show the anterior chamber angle, part of ciliary body, but it's difficult for us to see the lens uniolar. Investigations of the optic nerve. We use slit lamp and preplaced mirror to evaluate the optic nerve, including disc catch defects, disc catch bleeding, and cup-to-disc ratio. Visual field examination is used to measure the function of the optic nerve. The report is very intuitive, and the black spot indicates that the optic nerve function is impaired. OCT is an objective examination to assess the damage of optic nerve fiber layer. The green color indicates normal, while the red color tells us that there is damage. The differential diagnosis is acute iridocyclitis. This table shows the main differentiating features of acute angle chloride glaucoma and acute iridocyclitis. IOP in acute angle chloride glaucoma increased significantly, while it's normal in acute iridocyclitis. The pupil in acute glaucoma is dilated, while it's normal in acute iridocyclitis. Now, let's look at the treatment for acute angle chloride glaucoma. We need to reduce IOP as soon as possible to protect the anterior angle and the optic nerve. We can use topical beta blocker, alpha agonist, and mannitol. After IOP is reduced, pilocarpine can be used to constrict the pupil. If medication fails, laser therapy or microsurgery should be considered. Let's briefly summarize. Acute angle chloride glaucoma attack is a serious condition caused by a rapid increase in IOP. Slit lamp examination can reveal conjunctival hyperemia, corneal edema, shallow anterior chamber, dilated pupil, and even pigmentation, and glaucomatous flash. These are my references. And this is the end of today's section. Thank you. See you next time.